Greetings, pharmacology friends, neuroscience friends, behavioral medicine friends, everybody who is here. Thank you for coming to hear about antipsychotic medications. The purpose of this talk is a general overview of the two main classes of these medications. We will not be going over very in-depth pharmacology. Instead, this is going to be more of an introduction to this class of drugs. Just a little bit of a background with regards to the origin of the theory behind schizophrenia. Initially, the predominant theory was based upon DMT, and endogenous DMT production is something that is present in all humans, and that's a discovery that was made in the 1950s. DMT is a highly hallucinogenic substance when given to individuals, and so after discovery of it as a substance, it was found that it is a natural presence in blood and urine of individuals. As research went on, scientists and physicians noted that DMT levels were higher in individuals with a range of psychotic symptoms. In the 60s, we saw really that the DMT hypothesis was completely eclipsed by the dopamine hypothesis. And in the 60s, that's when dopamine itself was first recognized as a neurotransmitter. And in experiments, they found that newly created what we call neuroleptics, that's our other term for antipsychotic medications, neuroleptics blocked dopamine transmission. And when dopamine receptors were blocked, it was found that psychotic behaviors were decreased. When you look at the fit of a neuroleptic medication, especially chlorpromazine, the fit for neuroleptics for the dopamine receptor, in particular the D2 receptor, was a really good fit. And so this was taken as a sign that using medications that block dopamine relieve psychotic symptoms. So this has been really a predominant hypothesis. And that really persists today, is that schizophrenia is mainly mediated by a hyper expression of dopamine and a different type of expression of the various receptors. However, as time has gone on, we've all realized that the story doesn't really end with dopamine. Yes, there is dopamine dysregulation. However, it seems to be true as well that alterations to the serotonergic systems, the sympathetic systems like norepinephrine, epinephrine, acetylcholine, and GABA are all mediating different types of symptoms where we see dopamine really associated with positive symptoms. But you may know that there's also negative symptoms involved. So the story is more complicated than dopamine. Another thing to take into account is that, look at this, is that we have multiple dopamine pathways in the brain. So there's two in particular that are of interest to anyone who studies the dopaminergic system. And to really simplify it, we have two pathways, one of which originates in the ventral tegmental area, travels up through these limbic areas, and limbic describes the areas of the brain associated with emotion. They further go on to branch off into cortical areas associated with decision-making and with fine, complex controlled motor movements. The other pathway originates in the substantia nigra pars compacta, and that's a deep nuclei within the brain. It is a black set of nuclei, so it's easy to visualize with the naked eye. This is what we refer to as the nigrostriatal pathway. So it originates in the substantia nigra and then branches out through the area of the brain we call the striatum. And this pathway is really implicated in motor movement and motor patterns. However, the striatum in and of itself is also associated with motivation to some degree and also planned behavioral patterns. So I really want you to appreciate that when we are altering the dopamine system, we're not just targeting one specific thing. We are hitting receptors that are members of the family of both of these really large systems: habit acquisition, motor, movement, emotions, and cortical areas. The first class of neuroleptic medications that was developed are now what we call traditional antipsychotics. You'll also hear them referred to as typical antipsychotics. And in dopamine first being discovered as a neurotransmitter, and we found that this class of medications blocked dopamine receptors and had a high attraction or affinity for them. This class of medications is designed to mainly bind to and block dopamine receptors. There are 5 types of dopamine receptors in the brain. The strongest attraction for these types of medications are on the D1 and D2 receptor subtypes. And generally in the body, when we think of any kind of receptor with an odd number after it, that's usually an excitatory receptor. So when something binds to a dopamine type 1 receptor, we get increased dopamine activity. Whereas anything with an even number is an inhibitory receptor. So the D2 would lead to inhibition of dopamine release. So we're seeing both of these being hit. But you also can't forget that the other 3 types of dopamine receptors are being hit as well. So depending on which medication you're using, we can have all 5 of those receptor subtypes that are hit. But what we do know is when you give one of these traditional or typical antipsychotics, we see a reduction mainly in positive symptoms. Positive symptoms are things that are present in a spectrum of psychotic behaviors, so hallucinations, delusions, things that wouldn't be observed in a neurotypical brain. Whereas negative symptoms are types of behaviors that are absent in somebody displaying psychotic behaviors that we would expect in a neurotypical brain. So those are things like flattened affect, lack of pleasure in activities, social withdrawal, isolation. And you'll notice here, when we're speaking about typical antipsychotics, we're really just targeting those positive symptoms. They don't have a huge effect on the negative ones, generally, as a class. These medications, they can be broken up by their chemical structure. We have the phenothiazines, which include the first medication that was developed in this subclass, chlorpromazine. And then we have the 2 butyrophenones, and that includes haloperidol, also sold as Haldol or Serenase, and that is one of the most commonly used medications, not just in schizophrenia, but in inpatient settings when somebody is exhibiting psychotic symptoms, which include intoxication with a hallucinogenic substance. In a perfect world, if we were giving medications to block dopamine receptors, we would really only want to block the ones that are associated with symptoms that are in need of treatment in psychotic disorders. However, as I mentioned, we have 5 different types of dopamine receptors, and they are located at various areas throughout the brain. We've got D1, D5 in the cortex, your thinking parts, and the limbic system, your emotional parts. D3 and D5 are present in the hypothalamus. Those areas, or that area in particular, can be broken up into different areas, but all of it is really involved in homeostasis. D1 and D2 we see in the striatum. Corpus means body, so the striatal body, which is where we have habit formation and drive to complete behavioral tasks. What this tells us is with impunity, these medications are blocking dopamine receptors, blocking them within various areas and pathways, and interfering with other functionality in the body in trying to target just really symptoms of psychotic states. So we would say that dopamine blockade and its effects are really brain dependent. Where in the brain are you blocking receptors, and what type of receptor are they? So when we have dopamine blockade in the limbic system, because that area mediates emotion, fear, anxiety, and typical fear responses, we see that there's a reduction in paranoia, fear, hostility, agitation, and then also the positive symptoms of delusion, which is a sustained idea, a prevalent idea or belief that is true to the patient but not supported by fact. Whereas a hallucination is, again, something that the patient perceives is real, but is more of an internal stimuli. So it could be hearing voices, seeing things, smelling things, hearing things. I said hearing twice, but things that are present in a prolonged state. So they're present in the brain experiencing psychosis, but we wouldn't expect them in most neurotypical brains. When we hit really low areas of the brain, like the brainstem areas, there's some really important nuclei down there. We have the reticular activating system, which helps you, literally go from states of sleep or sleepiness to arousal. That's the kind of area that gets turned on when your alarm clock goes off. You are now aroused. That's that area's job. We also see that it's not on here, but it's called your area postrema, and that area is responsible for monitoring the blood for levels of toxins. So it would induce vomiting in the case of poisoning. When we have dopamine blockade in those areas, we then suppress behavioral arousal and the vomiting reflex. In also suppressing activity of the reticular formation, we have a desirable effect in this case. There's something called sensory gating. Sensory gating describes your ability to filter out stimuli at any point in time that are not pertinent to the present moment. So if you even take a minute right now, if you pause the video and paid attention to the sounds around you, maybe the light is clicking, my fake fireplace is making sounds, my cat is scratching something. And you'll notice that your brain is able to filter those things. When you have really the loss of that ability, what we see is that we now pay attention to that stimuli. One of the things that people experience with hallucinogenic medications is like, wow, the world is so great. It looks like the leaves on that tree are dancing. Well, those leaves always did that. You just weren't paying attention to that. So sensory gating is a really interesting thing you'll see with hallucinogenic substances and in psychotic states. The HPA axis, HPA stands for hypothalamic pituitary adrenal. So this is an endocrine system that involves the release of various hormones, which are associated with a whole host of things. So when we have blockade then of a hormonal system, we will see alterations to things that we definitely do not want to mess with. So we have alterations of the menstrual cycle in females. There's difficulties with ejaculation in males and females. They both do that, I promise. And another thing that isn't written on here, but dopamine is really involved in prolactin expression. So one of the side effects of taking these medications is galactorrhea, which is lactation from a non-pregnant breast. So when we're blocking dopamine, we have kind of this disinhibition of prolactin release, which leads to lactation, and that's a troublesome side effect. The most problematic from a clinical standpoint is really blockade of things in that basal ganglia, and that is where we have this really strong association with the substantia nigra pathway. The basal ganglia is really associated with motor movement and motor manifestations. When we see dopamine blockade in that area, we notice what we call extrapyramidal effects. And that's just some terminology that's speaking about these main motor outflow pathways. So your primary motor cortex projects down in this really simplistic, believe it or not, pathway that passes through this area in the brain called the pyramids. So technically, anything outside of this main pyramidal tract is considered extrapyramidal. So when we mention extrapyramidal symptoms, it's not the best terminology because there's so many extrapyramidal pathways. But if you want to think about the basal ganglia, think about its mediation being really strong with absence of movement. And this is really the opposite of what you would see in Parkinson's disorder. So that involves a damage to the substantia nigra and then damaged communication with the basal ganglia. So we see a resting tremor. So it's really important in suppressing movement when movement isn't desired. So you will see these patients who are on sustained doses of these medications start to exhibit symptoms that closely will mimic Parkinsonism. You can see pacing, rocking, purposeless activity. Dystonias means bad or deranged. So that would be abnormal muscle contraction, so muscle spasms and abnormal posturing, and tardive dyskinesias, which explain hyperkinetic, disabling movements. We also call them choreiform movements. So they are purposeless movements that definitely interfere with normal functioning. So we're getting all of these side effects because this is not a specific medication. It's what we call in pharmacology a dirty drug. Not dirty in that it's poisoned, dirty in the fact that it is hitting every dopamine receptor in the brain without specificity. So as I mentioned, ideally this medication would do just what it's supposed to. It would block dopamine type 1 and type 2 receptors, mainly in, these cortical areas, in limbic areas, so that we can suppress positive symptoms. When you give a medication like haloperidol, you will see that that's what they're designed to do, ideally, is block the dopamine type 1 and type 2 receptor. Nothing in the brain, though, is simple in any way. It makes life difficult in neuroscience, but also really interesting. Nothing in the brain is an island. Everything works together. So it turns out when we're altering this pathway, not only are we altering activity of the dopamine receptors, we also end up messing with transmission of things like serotonin, noradrenaline's the old school name for norepinephrine, and even of histamine. And if you think of what histamine does, when you take an antihistamine, you get really sleepy, right? Like Benadryl. So we're seeing all of these widespread effects because this is a non-specific medication. The more specific a medication is for a particular subtype, the fewer amount of side effects there are. So we can expect lots of side effects in addition to the dopamine side effects we just mentioned on the prior slide. But when we're messing with the whole cholinergic system and getting acetylcholine blocking, we're seeing essentially anti-parasympathetic activities. So you start to see things that you would normally expect in sympathetic state. So that's the opposite of rest and digest. It's when you're exercising or excited. So fast heart rate, reduced GI activity, reduced energy to urinate, blurry vision because of pupil dilation, dry mouth. When you're messing with norepinephrine, you're also getting low blood pressure and getting really sleepy. The sleepiness is also indicated with histamine blockage. So there is a whole host of side effects. So I don't want you to think that typical antipsychotics are great, right? They have a whole host of side effects, and their benefit is that we've known about them for a long time. They're relatively safe. However, they are associated with a large amount of aversive side effects. The easiest way to get somebody to not adhere to their medication regimen is to make it aversive. All right, so what we've hit on so far are these first four subtypes. The D2 is a type of dopamine receptor. The muscarinic type 1 is an acetylcholine receptor. H1 is your histamine. If alpha, that means it's norepinephrine that binds to it. So those are things that are targeted by these traditional antipsychotics. Now you will see two newer things in there, 5-HT, that stands for 5-hydroxytryptamine, and that is the way we refer to serotonin. There's some good things here. So anti-EPS means anti-extrapyramidal symptoms, question mark. We seem to think through observation that when you target this receptor, we suppress extrapyramidal symptoms, which is good. We also see satiety blockade when we're messing with another type of serotonergic receptor. Satiety is fullness, like when you eat to being full. That's called satiety. So satiety blockade would be a removal of that stimuli, so a difficulty in perceiving a feeling of fullness. So where does this come from? We haven't spoken about these yet, so we're about to. All right, my favorite type of thing, neurons and receptors and vesicles releasing things. So what we've spoken about so far are our typical antipsychotics. So we talked about chlorpromazine and things of that nature, but now we are on to the atypical antipsychotics. And this has an interesting story in that when we observe individuals on hallucinogenic drugs, you might see that the effects from those substances mimic what we see in psychotic states. So LSD, for example, can induce psychosis. It completely messes with sensory gating, hallucinations are present, and when somebody comes into the emergency room with acute intoxication with a hallucinogenic substance, we know when we give them an antipsychotic that resolves their symptoms. So here, the thinking was, if we know that LSD can induce psychosis and we can figure out where LSD works, perhaps we can develop a kind of medication that just blocks those receptors. And hence, lo and behold, we developed a new class of antipsychotics called the atypical class. So these are still going to do the old school thing by blocking dopaminergic receptors. However, they are more specific. They are mainly designed to recognize and bind to the D2 subtype specifically. However, we are now introducing two brand new receptor targets, these two serotonergic binding sites, the 2A and 2C receptor. Atypical antipsychotics bind to both of those. Here is a whole list of atypical antipsychotics, and if you're looking here just at the trade names, you might recognize some of them, like Abilify, Seroquel, Zyprexa. These are definitely marketed more heavily now because of their... My cat's going to kill my dog. Because of their ability to work in this behavioral mediating way. So they're advertised now for an adjunct to anti-anxiety medications and antidepressant medications. These medications, again, they are adding these two serotonergic targets to the D2 or the dopamine effects that we see with the typical antipsychotics or traditional ones. Remember, though, when we have more specificity, we have less side effects. This is a class of medication that is way more specific than our typical antipsychotics, which means we will have less side effects. And as we mentioned on the slide prior, because we are targeting this very specific system, the 5-HT2 system, we seem to have some protective effects against specifically extrapyramidal symptoms. So what does something need to be in order to be classified as atypical? Well, first of all, it can't be the traditional, cannot be a typical one. So to clinicians, if you're going to be prescribing medications or suggesting medications, they have low chances of causing extrapyramidal side effects. They also differ from the traditional ones in that we see improvement with negative symptoms, which is great. It is hard to treat negative symptoms, and this class of medication seems to hit them a little bit better. If you're selling drugs and you're trying to market atypical, we would call them, they're new, they're different. To an economist, they would call them expensive. These cost way more than traditional antipsychotics, which is why you see things like haloperidol used in a lot of clinical situations. It's old, it's been around a long time, we know all of its pharmacokinetics, and it is low cost. If you ask me, I'm a pharmacologist, so I would say in order to be classified as atypical, it would have to target the serotonergic type 2 A and C receptor subfamily types and the D2 receptor and block both of those. They have to antagonize 5-HT2 and D2 receptors. So those are your atypical antipsychotics. Quickly, I'm just going to pull out one of these drugs quickly, Clozapine. Clozapine, or Clozaril, that's its trade name. This is the only drug effective in treating treatment-resistant schizophrenics, meaning if you have tried other things, this is the medication that seems to work. So guess what? When we have to pick our drug that is really our first line, why not choose the one that works and individuals have tried other things? This is also used to treat Parkinsonian patients who have developed psychotic symptoms because they're on medications that increase dopamine. So if you give them a dose of a med and it's a little off, they'll start to manifest schizophrenic symptoms. Whereas what we were just mentioning, somebody taking medications to block dopamine will exhibit Parkinsonian symptoms. This medication is clinically superior to our traditional antipsychotics. Negative symptoms, no EPS, no extrapyramidal side effect, and also less cognitive impairment. It may improve in the negative symptom spectrum, this core deficit that we see in psychotic states. So verbal fluency becomes more present. So it's not a short answer to something. We call that alogia. There's less thought blocking, psychomotor speed increases, verbal learning and memory, because there's so much, gross neuroanatomical damage in schizophrenic brains. When we see increases to verbal learning and memory, that's letting us know we're perhaps not getting that expected damage to the areas that mediate that. Clozapine itself is a weak D1, D2 agonist, which means it binds to those receptors, but not really tightly. And if it can't bind really tightly, it can't have a really strong effect. Instead, it is designed to have the highest attraction or affinity for the serotonin subtypes of receptors that we're trying to target, because that's where we know LSD binds. And if we can stop the symptoms due to LSD intoxication, then we can definitely use that target to stop the presentation of psychotic symptoms. All right, so that's what you learned today, your brief foray into the world of antipsychotic or neuroleptic medications. I hope you learned something. Stay smart, and I'll see you all later.